On the Moon, medical care starts with a constraint. There is no regional hospital nearby, and Earth cannot send a specialist in real time. A typical outpost clinic is compact, limited imaging, limited lab capacity, and a small team whose skills must cover many roles. Signal delay means advice from Earth arrives late. Local hands still do the work. This is Lunar Frontier on Quantum Files. Educational storytelling grounded in current engineering concepts from NASA programs and published research. Timelines are speculative. Physics is not. This episode looks at how space medicine would actually run under rock. Radiation dose, clinic design, surgery under delay, drug supply, behavioral health, and evacuation criteria. The goal is not drama. It is understanding the systems that keep a crew treatable when distance is part of every decision. We will walk through the main pieces in order, from exposure control to the clinic floor, then to supply, behavioral health, and evacuation. Beyond Earth's atmosphere and magnetic field, galactic cosmic rays and solar particle events raise radiation exposure. Habitat design answers that first with mass, regolith cover, buried modules, and storm shelters for solar events. Even with shielding, dose still accumulates over a tour. Crews track exposure with monitors and badges. Mission planners set career limits, restrict some surface work, and move people into shelter when forecasts worsen. From a medical view, radiation is managed like other scarce resources. You measure it, budget it, and design operations around it. Every unshielded hour on the surface adds to a record that follows the crew member home. That is why depth is not only architecture, it is preventive medicine built into the city. Surface work still happens, but it is timed, monitored, and limited by the same medical logic that sets career dose caps. A lunar clinic is closer to an advanced aid station than to a full hospital. It carries the tools mass and volume allow, staffed by people cross-trained for the cases most likely to occur. Ultrasound may be available when heavier scanners are not. Blood tests are rationed because reagents and machines are limited. Sterile space is small, so infection control is strict. Telemedicine can guide diagnosis and procedure steps when the link is stable, but latency means Earth cannot scrub in. So the clinic focuses on triage, stabilization, wound care, infection control, and clear escalation rules. It stocks for probable emergencies and writes procedures for communications outages. A well-run clinic looks ordinary on purpose. Labeled drawers, practice teams, and checklists that still work on a bad day. Capability is defined in writing. What can be treated on site, what requires remote guidance, and what must wait for evacuation. Operative care on the Moon has to respect low gravity and delay. Anesthesia needs continuous monitoring. Bleeding and fluid behavior change when weight is reduced. Loose instruments become hazards, so trays, tethers, and restraints matter. A remote specialist can advise, but only within the limits of light time and bandwidth. That pushes teams toward protocols written before launch, rehearsed checklists, and, where mass allows, robotic or assisted tools. If a case exceeds local capability, the correct path is stabilize, reassess, and decide on evacuation, not improvise beyond training. Delay is normal here. Capability is inventory, skills, and knowing when to stop. Training has to cover the physics of the environment as carefully as it covers anatomy. Rehearsal matters because the first complex case should not be the first time the team uses the checklist. Medicines degrade with time, heat, and radiation. On Earth, pharmacies hide that behind large warehouses and frequent restock. On the Moon, Storage is a locker with a hard clock. Planners track which drugs expire first, which need cold storage, and which can be compounded or substituted on site. Pain control, antibiotics, cardiac drugs, and behavioral health medications each need a resupply plan and a shortage plan. Inventory discipline is clinical work. So is deciding substitutions before a shortage hits. A settlement that cannot restock key medicines remains dependent on the next lander. That dependency is part of medical readiness, not an afterthought. Cold chain failures, expired stock, and missing alternatives become clinical failures as quickly as a broken monitor. Isolation, confinement, and an unchanging habitat are medical risk factors, not soft extras. Sleep disruption, irritability, and withdrawal can degrade performance and raise accident risk. Countermeasures include private volume, fair duty rosters, meaningful work, reliable contact with Earth, and access to counseling. Exercise and nutrition support mood and cognition, but they do not replace behavioral health care. Crews need people trained to notice early changes and a culture that treats those changes as operational data. Under rock, mental health belongs in the same readiness model as life support and medical supply. Ignore it, and the failure mode is human error that looks like a hardware problem after the fact. Early check-ins and confidential support are cheaper than recovering from a preventable incident. Evacuation is the last medical option and the costliest. A patient may need care the clinic cannot provide. A return seat may not be available on the needed date. Launch windows, suit time, and patient stability all enter the decision. Criteria should be written before a crisis. Which conditions require Earth-level care, what stabilization is required for transit, and who has authority to call the move. Sometimes transit risk is higher than limited local care. Sometimes local care is not enough. Either way, the decision is operational, with named people and documented thresholds. Saying we cannot finish treatment here is part of responsible medicine on the frontier. The paperwork is dull on purpose. Dull criteria beat improvised arguments when a crewmate is already unstable. Space medicine under rock is dose tracking, a clinic sized to reality, surgery planned for delay, medicines managed as logistics, behavioral health treated as readiness, and evacuation rules written in advance. Those pieces decide whether a crew remains treatable when Earth is far away. Next time we look at who gets to stay, safety zones, operating rights, and how neighboring activities can interfere on a shared moon. Lunar Frontier continues.